Good morning, everyone. We're going to start off this lecture on communicable diseases. If you look at your syllabus, you'll see that your resources. First off, we have your maternal child textbook by McKinney, and this information can be found in chapter 41, starting on page 903. And also your ATI book has some good information in chapters 35 and 36. 35 will cover the immunizations and immunization schedules. And then chapter 36 actually starts looking at your communicable diseases. So some basic things that you will need to know for this particular unit. First of all, what is a communicable disease? Communicable diseases are diseases that can be transferred or spread from one person to another. They can also be spread by air, blood, or body fluids or contact, either direct or indirect. The things that causes communicable diseases are things like bacteria, viruses, fungi, or parasites. Transmission of the disease is dependent on which disease it is, which makes sense because we do have like strep, which is a bacteria that is a communicable disease. And then we also have things like COVID, which is viral. So different methods or different types of carriers depending on what the disease is. Hand washing is always important. We preach this as like one of the first skills you learn in nursing school, and that's for a reason, because we know hand washing is really the #1 way to prevent the spread of disease. And so I want to remind you that good hand washing is imperative. Some of the diseases are also transmitted by airborne, others by droplet, and some by contact. And we'll discuss those a little further as we get into some of these other slides and we look at each of these diseases or some of these diseases individually. The individual diseases, it's important that we understand the chain of infection or the factors and conditions that lead up to the person actually becoming infectious. So for a pathogen to maintain its infectious state, it has to be transmitted to another host, and then therefore certain factors and conditions must be present for the disease or the infection to actually begin. Some of these components and their relations are often referred to as your chain of infection. The major variables in your chain of infection include the agent or the organism that's causing the infection, the reservoir or the environment in which the agent resides and multiplies, the portal of exit, the route by which the agent leaves the host, the transmission mode, the portal of entry, which is the route by which the agent enters the new host, and also host susceptibility, and those are things that are internal or external environmental factors that increase or decrease the likelihood that the host will develop the disease. And this kind of makes sense if you think about it, just based upon which organism you're dealing with. The person, just because they're exposed, may not become infected. It all depends on some of their susceptibilities and their body makeup as well. But all these conditions have to be right in this chain of infection for the person to become ill with the disease. So changes in any one of the variables results in a change in the presence, intensity, and frequency of the entire infectious disease process. I know we're all kind of sick at COVID, but if you kind of think about it, for anybody who's had COVID and then had a reinfection, typically you don't get as sick the second time, even though it is a different strain, because there is a part of your immune system from the susceptibility standpoint of your host that recognizes that, hey, I've seen something like you before, and so it keeps the person from getting as sick the second time around normally, not always, but normally. But also when you think of susceptibility, you also need to consider that the patient may be immunocompromised for some reason. What is their nutritional status at the time that they are getting sick? How much stress are they under when they're getting sick? So there's a lot of different things that go into somebody becoming sick, but this chain of infection is an important thing to understand. Next thing we need to talk about is transmission. How are these different disease processes transmitted? And this is important to us as nurses because if we understand the mode of transmission, then we know what kind of precautions we need to utilize to help keep the spread of this from getting any further or more people becoming ill. So some of the modes of transmission are like airborne. We have fecal oral, we have direct contact, whether it's saliva, breast milk, through birth, sexual contact. You have vector, which are like your insects, like mosquitoes and ticks. Blood. Blood transmission can occur through transfusions, which we always associate that, but we can also get it through contaminated needle sticks. Hence is the reason we tell you not to recap or use the one scoop method. That's why things go into Sharps container. But it also can be transmitted through pregnancy, through placental transmission. If you've ever seen a baby be born, there's a lot of blood that gets that's present, and so things can be transmitted that way as well. Certain spores are found in the soil, and I know when we get to fourth semester we'll talk more a little bit about anthrax, and that's one of those that is transmitted via spore with farm workers in particular. And tetanus is also a spore type infection. That's why we see both of those a lot of times coming out of soil, because they're spores. So just a good understanding. And so when we look at each disease process and knowing how it's transmitted, like I say, we know certain things like COVID-19. Everybody knows it's airborne transmission. We put a person under airborne precautions. That's why they go in the negative pressure rooms. That's why we use those N95s, because just simple, basic, standard precautions are not enough. So understanding transmission is important when we're looking at these communicable diseases. Briefly about like the chain of infection, how things are transmitted. We need to understand what actually happens to a person once they're exposed. And from that time they're exposed until the time that they are well, there are different stages of the disease process that they go through. And we're going to look at each one of these a little more closely on some individual slides coming up. Okay, so the first step in these stages of disease would be the incubation period. And this is the period between exposure to an infection and appearance of those first symptoms. Depending on the disease process, this incubation period can vary in length of time. For instance, the incubation period of something like RSV or the respiratory syncytial virus, which happens in younger children. I mean, it's kind of like a bad cold, but it can be quite severe, can be anywhere from 4 to 6 days. Strep throat, which many people have had to deal with, incubation period for it is usually 2 to 5 days. And chickenpox, or that varicella, it can be anywhere from 10 to 21 days. And it's important to know that, because some people may think, hey, you know, my kid was exposed to chickenpox a week ago and I still don't see anything, and they think they're in the clear, but that is not the case. So understanding those incubation periods is important, because it kind of lets you know from the time of exposure, when could you expect to potentially see those first signs or those first symptoms start to appear. It's at this point the person's been infected, and the virus is then, or the bacteria is replicating. I always like to think of replication more with viral infections. But that's when it's entered your body and it's rapidly making more of themselves to make you sick. And this also tends to be the stage of disease process where people are typically the most infectious, which is kind of bad because you don't even know that you're sick yet. That's why, you know, you see with COVID-19, if you've had exposure, that's why they started isolating people or putting people in quarantine before any signs and symptoms, because we knew that you could still be potentially infectious to other people. And so we had those incubation periods kind of covered when we did that. But it is an important thing to understand your incubation periods, so you can kind of know when you might start to see, and you can also tell parents whose children may be potentially exposed to something when they should see those signs and symptoms, and when the time would be like, okay, it looks like you dodged the bullet here and maybe your child did not get sick. Next, we have the prodromal period, and this is the period of early symptoms of disease occurring after the incubation period and just before the appearance or the characteristic symptoms of the disease. So this is where they're just not feeling quite well. They know they don't feel well. They know maybe they've been exposed. They may not know they've been exposed to something, but these are the early symptoms that occur with the disease. before the characteristics. So during this phase, the pathogen will also continue to multiply. And like I said, you'll kind of have those general signs and symptoms that something's not quite right. So this is usually as a result of the activation of your immune system. So all these things make sense if you know about your immune system and how it works. When those white blood cells start to multiply, we may have lymph nodes start to kick in and start spitting out the cells that are needed for protection. Those things are what come together to cause that inflammatory process. This is what also causes the body to have fever, which are all good things if the pathogen is present, because that tells us that your immune system is working properly and it's doing its job. So that's why we see these things like fever, pain, soreness, swelling, or inflammation or inflammatory processes going on. So we have the acute period, which is exactly what it says. This is the acute or active phase of the disease. And this is where your symptoms are the most pronounced, and you also have that strong immune response. So if you think about, I'm going to talk about the flu. If you think about the flu and how it works, you know, you have exposure to that. We have your incubation period where those cells, I should say, the virus is replicating itself. And then you kind of start to have those mild things in that prodromal phase where you kind of have like that scratchy throat. You just kind of not feel good, but you don't really feel bad. And then all of a sudden, bam, you get hit with the acute period of the disease where suddenly you have all kinds of body aches and pains. You have high fever, you have sore throat, you have the chest congestion, and all the fun stuff that goes along with the flu. But all those things are happening, and this is where your immune system has really now kicked in and is starting to work on dismantling and getting rid of the viral load that's in your body at this point. Our last stage of the convalescent period of disease process, and this is your recovery period. This is the period where your classic signs and symptoms now have dissipated, so you may not have a fever anymore. You may have a little bit of a sore throat. You may still have that lingering cough that just kind of hangs on for a while after you've had the flu, but you're not acutely ill at this point. The thing to note here is that the person can still potentially spread infection in this convalescent period. And this is why I've written down here in the notes, you can see that this is why we tell COVID patients to wear masks for 10 days, even if they don't have any signs and symptoms anymore, because there still is the chance that it could still spread this infection to other people. This is also why with pediatric patients, and parents always want to know, when can my child go back to school? This is why we always tell them that they can't go back until 24 hours fever-free without the use of any kind of medication. So if your child has been home sick with the flu or strep throat, we say 24 hours on antibiotics for strep throat and fever-free for both of those for 24 hours without the use of like Tylenol or ibuprofen, because that's a good indicator that you are no longer in a period where you could still spread this to other people. Immunology or immunity, and we know that there are two types of immunity that the body uses to, keep you from getting sick or from helping you to heal, but this is mainly to keep you. And so we have active immunity and we have passive immunity. So active immunity is when the person is exposed to disease or the organism and makes his or her own antibodies. It's active immunity, and this is permanent or long lasting. It's kind of like, I know you get a cold, your body makes these antibodies to the cold. So the next time it sees that cold, you'll never get that particular cold virus. You'll get other cold viruses, but you will not be able, you may be infected with the same cold virus, but you will not get sick with it again. That's why people have reoccurring COVID infections, because they see one strain and then their body gets exposed to the other. But for instance, if you had Delta and you've gotten through that, if you were to be re-exposed to Delta, you should not actually catch Delta again, because your body has already made those antibodies, and that's permanent and long lasting. So you have natural active immunity. This is the person actually has the infection and is then immune to the disease. Like I said, getting something like COVID-19 or the flu. And then we have vaccine-induced immunity, where your body, again, you're given either a portion of it or something to mimic that particular virus, and the body then actively makes those antibodies. So you have active immunity to a disease that comes from being immunized with a killed or weakened form of a disease. So again, this would be, like I said, it's just like getting sick, but they give it to you in injection form. Your body recognizes like, hey, this is not normal. Your body makes those antibodies, and then your body will be able to protect you if it is reintroduced or that pathogen in some way finds its way into your body. Your immune system will come in and take care of it before you actively will get that disease process again. And that's why we do immunizations, as to keep children from developing diseases that we know have long-term effects and consequences. Like you could lose hearing. They may have vision problems. They may lose their ability to walk. I think of polio. Thank goodness that one's been, pretty much taken care of for a long time. But that's what vaccines are designed to do, is to prevent them from actually becoming gravely ill with these diseases. And then the other type of immunity would be passive immunity. And this is when a person is given antibodies to a disease, excuse me. This immunity is temporary and lasts only for a few weeks or months. And I think of this like going down, I don't want to get ahead of myself, so I'll save my thought till we get a little lower here on this slide. But natural passive immunity is when antibodies are passed from mother to fetus by way of the placenta. And this is one of the main reasons why when we're looking at that immunization schedule, you will notice that they get the MMR vaccination at 12 months, because we know that when the mother has been vaccinated and has that MMR, they have those antibodies, they are passed on to their child. And so if you were to give that shot before this, the body wouldn't actually start making their own antibodies because they think they're covered. So this is something that was passed on from mother to child. We see this also, sometimes mothers can pass certain immunities for a short period of time through breast milk. That's one of the reasons they encourage breastfeeding, especially that first part with the colostrum, is because they can pass over these immunities and give this passive immunity to the child when they're young. The other one is the natural passive, passive immunity, where they're given through immunoglobulins to provide immediate protection against a disease. And I keep going back to COVID, probably because it's just the most recent thing and it's in our minds. But this actually occurred when we were doing some of the immunoglobulin therapies, or giving convalescent plasma and stuff like that to COVID patients from people who had COVID. They're passively giving those to somebody else whose body needs to be amped up to fight that infection. So I hope that made sense. I kind of stumbled there a little bit, but just know that natural passive would be passing it from the mother to the baby, and then just the regular passive immunity is given through like some kind of immunoglobulin type therapy. We need to talk about or mention here, and that is herd immunity. And this limits the spread of infection and reduces the probability of infection by immunization. So this is what we kind of saw with our COVID-19. I think of smallpox when I think of herd immunity. Smallpox was something that we used to do immunizations for when I was young. It was a nasty disease, left people with big, like, scarred areas on their body. But through immunization, we were able to do herd immunity and pretty much eradicate this one from existence. So this is when people get immunizations that help stop the disease from traveling from person to person, so that there's less chance that they're going to have an outbreak. This is what we tried to do as well with COVID. So people unable to take the immunization due to a weakened immune system or serious allergies to the immunizations have an increased protection when others take the immunizations to keep the disease from spreading. So this is one of the reasons we encourage vaccination, because there are going to be those people who, because their immune system is so weakened down, and I oftentimes think of my cancer patients in this category because of chemotherapy. They sometimes cannot take vaccinations. Like flu season, for instance, we have to be kind of careful we don't give them the nasal spray as opposed to we can give the injection. But if you have somebody who is highly allergic to eggs and then they have a weakened immune system, they don't really have a very good avenue to receive a flu vaccine. So by everybody else doing their part and getting vaccinated and hopefully decreasing the risk of transmission or the spread of transmission, the risk to those people who are compromised goes down significantly if we kind of do our part. And herd immunity was a word we heard thrown around a ton with COVID-19. You know, there's a lot of controversy over vaccination, and we just need to let everybody get it naturally. The sad thing was we didn't know who was going to get COVID-19 and be asymptomatic and who was going to get COVID-19 and be on a ventilator and dying. And I'm not trying to get political on anybody. Everybody has their own opinions, and you're entitled to those. But this is a term we've heard a lot just recently, but this is what herd immunity means, is that just basically we've got enough people immunized and are immune that the risk of significant transmission, like what we saw with COVID-19 prior to vaccinations, should not occur. For you guys. Now, I know you guys have the answers, but I want you to think about why these are important. So the question is, the first line of defense in the innate immune system are having up-to-date vaccinations, skin, intact mucous membranes, or good hand washing. And this is your first line of defense in the innate immune system. So having up-to-date vaccinations sounds good, right? It is something that we can use in defense for our immune system. However, it is not a first-line defense of our innate or the born with, that's the key word there, innate immune system. Your skin, however, we know your skin is one of your number one barriers of protection, so that one does become true. We're doing that true-false thing. Intact mucous membranes is also true or false. It would be true. It is also something that is innate to us, that is a first line of defense. We know that if the mucous membranes are intact, the risk of transmission is significantly less. And I think of HIV in particular with that, with this one. And then also good hand washing. Even though we know hand washing is the number one way to stop the spread of infection, it does not ring true on this one because it is not one of those innate parts of the immune system. It's something we do, but it's not the correct answer here. So your correct answers are your skin and intact mucous membranes are the first line of defenses in the innate immune system. Look at some of these different types of vaccines, or these are the things that are like given to people to prevent infection. So we have inactivated or killed organisms. An example of this would be like your polio vaccines, rabies vaccines, and your flu injections for the most part. Okay, I will say that we do have a influenza that's the nasal spray. That's why it says injection. The one that's nasal spray is actually not inactivated, but these are a lot of the vaccines that we give are these inactivated or killed organisms. So the virus is disabled and it's unable to actually replicate itself, okay? But it still contains enough of its original material or characteristics that it will stimulate the immune system to say, hey, I know you're not supposed to be here. I need to create antibodies so that if I ever see you again, you're not going to get sick. So this is not as strong as live vaccines, and that's why we often see boosters that are required to keep you immune, okay? And then you have your live attenuated or your weakened viruses, and these are things like your MMR vaccines and your varicella vaccines. And these work well for extended periods of time, usually, like it says, a lifetime, with 1 or 2 boosters. And that's very common with MMR and varicella, that is given in a series, so you get more than 1. And this is very similar to if you actually had gotten sick with the infection and developed that naturally on your own. So these live vaccines do have to be kept cool to stay alive, so they don't travel well. So these are things that if you're ever working in a clinic, these would be ones that you would pull out of the refrigerator, these live attenuated virus or vaccinations. People with a weakened immune system or people with chronic health conditions may not be able to take these since they do actually have a small bit of weakened virus in them that could actually make them ill. And this is what I was talking about earlier with some of the oncology patients. I know my patients were not allowed to take any kind of live attenuated vaccine because their immune system was so weakened that they could actually become sick with the particular disease process that we're trying to prevent. And then we have these acellular vaccines. These are things like your pertussis vaccine and your Hib vaccine. And these contain fragments of cells that stimulate the immune response, but does not contain the whole cell. So it just has part of it enough that the immune system will do its job by creating these antibodies, but it is not the whole cell themselves. And then we have our toxoids, and these are things like tetanus and diphtheria. So the toxins produced by the bacteria are inactivated, so they can't harm you, but they still can stimulate that response that we're looking for to protect you. These are very effective. Boosters are also needed, and that makes sense because when you look at that schedule of vaccinations, you will see that they are given in a series. We all know that tetanus shots we take for the rest of our life. We know that there's a 10-year window before you need to have another tetanus shot, or if you have an exposure, they say 5 years. And what does that mean? That's one of those things, like if I were to go outside and I was messing in the barn and I got stepped on a big old rusty nail and I got it all cleaned out, the first thing the doctor or nurse would ask me is, when was your last tetanus shot? Normally, if I said 7 years and I had not had an injury, they would have been fine. But because I stepped on that rusty nail, I'm inside, or outside, I should say, of that 5-year window, they're going to make me take another tetanus shot. And then we also have these subunit of virus, and you may hear them called recombinant vaccines or conjugate vaccines. These are ones like our Hep B, which are small fragments of viral protein are used. And again, just introducing enough of the agent will produce your immune system, or have your immune system produce that response that we're looking for by creating those weakened, or I should say, by creating those antibodies to prevent you. And these are also vaccines that can be taken by people with a weakened immune system, unlike your live attenuated. So these are all just the different types of vaccinations that you'll hear about. And then I don't have on here, but then we have like our MMA ones, which are things like that we've done with COVID. But we're not going to get into those, and I don't expect you to know that. But COVID was a little bit different because they worked with the RNA, like part of your actual cell synthesis. But they've been in production for a very long time as well. The different types of vaccinations, how do we administer them? Majority of them are IM or subcutaneous, so you can administer it either route. Some can only be done through subcutaneous, and then we also have some that are oral. So it's important that you understand how they're given, because if you give them wrong, the vaccination may not be effective. So some of the vaccines that are given strictly IM or through the intramuscular route would be diphtheria, pertussis, tetanus. That's why you see the DTP, the DTaP, DT, Tdap, TD. Those are all different variations of those three. Hib, or the Haemophilus influenza B, Hep A, Hep B, HPV, which is the human papilloma virus, your influenza, your meningococcal conjugates. That's the one that a lot of people take if they don't do it before they come to college. They recommend that you get this in college, especially if you're living in the dorms. And then also the PCV, which is for pneumonia. Things that can be given either IM or sub-Q vaccines are things like your inactivated poliovirus, that PPSV, which is another pneumonia polysaccharide immunization. This can be given for special high-risk conditions such as chronic heart disease, diabetes, and high-dose corticosteroids, because that one weakens down the immune system. Those high steroids do. Things that are given subcutaneously are your MMR, your varicella, the meningococcal polysaccharide vaccine, and then orally we have rotavirus. So those are the different routes of administration for some of the vaccines that are on the schedule that you'll see in Chapter 35 of your ATI book. So what are some nursing considerations when giving immunization? So the first thing is you need to make sure, of course, that the patient or the patient's parent, in this case, because we're talking about pediatrics, signs the permission form before giving the immunization. You also need to make sure that you give vaccine information that includes the purpose of why they're getting the vaccine, the possible side effects of the vaccine, and how to care for the child after the vaccine has been received. And once we start giving some of these vaccines in the hospital this fall, we do a lot of flu vaccines. You will see the vaccine information sheets that I kind of mentioned. There are actual forms that you have to record on in documentation that that particular form was given to the patient, and they usually actually have a code number that you have to enter. But it's important that patients have all the information they need prior to receiving vaccinations. And then, of course, you need to answer any questions that they may have about what they're going to be receiving. So know that some immunizations may cause a mild fever. They can have soreness and or redness at the injection site. You want to teach them about proper dosing of acetaminophen and the use of warm compresses on those tender sites. And also let them know that acetaminophen and ibuprofen are not recommended routinely due to the potential of decreased immune reaction to the vaccine, or it will not allow it to give the positive immune response that we're wanting to see. But there are going to be times where the child has a fever or they're just incredibly fussy because of pain, that we're going to encourage them that yes, it's okay to give the acetaminophen and or ibuprofen, but it's not something they need to do routinely. But make sure they also know how to properly dose the medication for their child. We're going to report any adverse effects that the patient may experience to the CDC. This is an important step because maybe for some reason we have a vaccine that has been tainted, or maybe it's not effective. The CDC needs to be aware so that they can then track the other vaccines that came from this particular lot and determine if it was a one-time occurrence or if it's something that they need to be working on to get those off the shelves and off the market so people can't use them. And this is why we document the lot number, the route, the site, the date of the vaccine. Particularly that lot number is very important if for some reason the CDC finds out that a particular lot of vaccine that was produced is not effective or potentially could be contaminated. They need a way of tracking down those patients who received that vaccine. So making sure we document that is very important. And then also, anytime we give vaccines or any medication, there's always the risk that the patient could have an allergic response to it. And this can happen with vaccines as well, to the vaccine itself or components of the vaccine. The one that most people probably think about is eggs. People who are allergic to eggs can't take certain vaccines. The one that comes to mind right off the bat would be the flu vaccine, because of the way it is produced. It uses egg components. So if you have somebody who has an egg allergy, they're not allowed to take a flu vaccine. So just to be safe, we always want to make sure that we have emergency equipment and an epinephrine or epi available for them. And you can see the ratio there of the concentration that should be available, that 1 to 1,000. And this is just another reason why sometimes when children receive a vaccine for the first time, the doctors would like for them to stay so they can be observed. This is why when people had their COVID-19 vaccines, we had to let them stay and be observed. is because there is always the risk that they could have an allergic response to that. They can be given if the child is mildly ill, but if the child is severely ill with especially a fever, a high fever, I should say, not just a mild fever, but a higher fever, it is contraindicated that the patient receive the vaccine at that point. We would wait until the child was feeling better before administering that vaccine. So it's important for you guys as students and as nurses, especially if you're going to work in any kind of pediatric setting, that you understand the immunization schedule, and that is, when are these vaccines supposed to be given. So these are all just different references that you guys can utilize. The CDC is the one who makes those recommendations for vaccinations, and you can see that there's a link there, or a place to tell you where to go, and you can find it on the CDC website. ATI Chapter 35 is also a great review for your immunization schedules. ATI Pharmacology Made Easy has some information there for you for drug therapy to prevent diseases. Also, I have added at the very end a slide that has a YouTube link that has a little mnemonic to help you remember the vaccination schedule. I will tell you that NCLEX expects you to have a good basic understanding of your vaccination schedule for children. So this is something that you do need to become familiar with. And it says on here, I just realized that I need to update this. The vaccinations have changed. They are recommending that children as young as 5 can get a COVID vaccine. It used to be 12, but it's actually younger now. As research is proving and studies are going on, that children as young as 5 can receive COVID vaccines. Considerations, there's some information for you from a nursing perspective on some of these vaccines. So you have specific contraindications to Hep B, that is yeast. So if you have a patient who is sensitive to yeast, they would not be allowed to take this Hep B. Hep A is important to give to children who are traveling, and depending on what state you live, the recommendations or requirements, I should say, for Hep A may vary. I know when I was a school nurse several years ago, the state of Oklahoma does require our students here to have a Hep A vaccine to enter K through 12, or to be actively beginning that series, I should say. And then in Missouri, that was not the case. So Hep A is one that depends on what state you're living in, but it is recommended that children do get vaccinated for that, especially if they're traveling. Your DTaP vaccine is safer now because only acellular components are used. So when we go back, they're only using part of it, not all of it. So those do make them safer. DT is for children younger than 7 years who cannot have the pertussis component of the DTaP. So that's that diphtheria, tetanus, and pertussis. So there are various formulations of that. And when I read those schedules, you'll see that there are multiple combinations that sometimes they are called. But just know it says just DT. It has the diphtheria and the tetanus. It's just lacking the pertussis component of the vaccine. And then Haemophilus influenza, or this HIB, was at one time a leading cause of meningitis in young children. But now that we've created a vaccine for that, we're able to keep this particular process from happening, which is a good thing for our young people. And a little bit more information for you. So the rotavirus is a live attenuated vaccine. It should be avoided if the child has a history of intussusception, which that is a condition that happens in the intestine where it kind of folds in on itself, kind of like a collapsing telescope. And it also should be avoided in children with severe or other GI disorders or severe combined immunodeficiencies. This is, honestly, rotavirus is something that most kids used to get before they were 1. It does affect the GI tract, but now we do, like I say, have vaccine for it. So that's a good thing, because you'll learn when we get to dehydration and hydration. Children under the age of 1 in particular can dehydrate very, very quickly. So this was a good vaccine they came up with. The pneumococcal vaccine protects children from meningitis, otitis media, which is ear infection. It means middle ear, and other types of infection. The pneumococcal polysaccharide vaccine is used for older children and adults, but may be used in children older than 2 years who have special medical conditions. So again, good vaccine here. Inactivated poliovirus vaccine has replaced the OPV, which was that oral polio that we all got to take. They used to put that on a sugar cube when I was young. Showing my age there. It contains, the OPV, I should say, contained a live virus, and which could lead the person to develop disease and therefore could cause some paralysis in immunodeficient children because they would contract it but not have enough immune response to actually, just have a minor one. They would actually get sick, or close contacts with those who are immunodeficient. So that's a nice thing. We have changed up that the way we deliver it from a live virus to the inactivated virus, making it safer for people to take it. There's some more. So influenza nasal spray is a live vaccine. I talked about this a little bit earlier with you. They do recommend that this not be given to children younger than 2, but it is safe to give to children over the age of 2 because it does have live virus in it. It's also contraindicated with children who have asthma or who have been wheezing within the past 12 months because flu is a respiratory type virus, so we don't want to put those children at risk. This can cause a mild flu, but it's made from a weakened form of the live virus. So again, that's why we don't give it to people who are immunocompromised, because it can actually make them sick instead of just stimulating the immune response that we're looking for. Influenza immunization is contraindicated in an allergic reaction to previous doses of the flu vaccine, or children or people who are allergic to eggs or egg products, or those who have moderate to severe acute illness at the time. And I always think of my grandson. I have a grandson that's 3 years old that is highly allergic to eggs, and he cannot take the flu vaccine as far as the injectable one. So maybe at some point we're hoping that he will outgrow this, is what the doctor is telling us. MMR, which is also a live attenuated virus. This is measles, mumps, rubella. That's what MMR stands for. This can cause a mild localized reaction, rash or fever. It can have moderate reaction that can cause things like some pain at the injection site, some joint or stiffness in the joints that can last for a few days. This one also can affect their platelet count, so they may have lower platelet count, which makes them more susceptible to bruising. And severe reactions are rare, but they can happen, and that can include things like deafness and some damage to the brain or long-term seizure problems. These are contraindicated in people who are allergic to the vaccine components, that are pregnant, immunodeficient, or who have a family history of altered immunocompetence. Caution is used if the patient has been recently given any kind of antibody-containing blood products, IV gamma globulin, or people say IVIG, and a history of thrombocytopenia, which is just a big fancy word for low platelet count. And if you break that down, thrombocyte is a platelet, and anytime you see penia, that means lower or less. So these people have a low platelet count, and we already know that this can also lower, we talked about that earlier, that the MMR vaccine can lower platelet count. That's why we have to be cautious with people who already have low platelet counts, because we may take them from 50 to 10 on that count, which there's a big difference, and the risk of bleeding goes up significantly with that. TB skin tests may be given before or at the time that the MMR is done, or 28 days later, and can also be given to children with HIV as long as they are not severely immunocompromised. So those are just some little tidbits to know about the MMR live attenuated vaccine. So the varicella vaccine is also a live attenuated vaccine. It is contraindicated for people who are allergic to components of the vaccine. You're going to hear that a lot, or had a previous severe allergic reaction. And a lot of times when you look at your information sheets for the vaccines, they will tell you potentially what components you're looking for. Those that are immunocompromised, pregnant, or have a family history of altered immunocompetence also are contraindicated to receive this. You're going to start seeing a pattern, if you've noticed with some of these, about what contraindicates the ability to give these. You're going to use caution if they've had a recent antibody-containing blood products or moderate to severe acute illness. And do not give if antiviral drugs have been given within 24 hours, and antiviral drugs should be avoided for 14 days after immunization. So that is something to keep in mind. You know, if you've got a child that's taken Tamiflu, those are antiviral drugs. You want to make sure that you're not giving those at the wrong times. The varicella vaccine is the one that is given to prevent chickenpox. It was introduced in 1995. You know, back in the day, the way we did this was natural herd immunity. If somebody's child got chickenpox, all the mamas in the neighborhood brought the kids over to get them exposed to it, to get it over with, so then they'd have that natural immunity that they had built by being exposed. But we have now developed a vaccine, which is kind of nice that we have this, so kids don't have to deal with chickenpox and the consequences from that, because some kids wound up with scarring and stuff like that from some of the lesions that were on their skin, and it could even lead to death, very serious implications. That did not happen frequently, but it is just nice to know that now we can prevent that with a vaccine. The slide said almost through. So meningococcal conjugate is given to children between the ages of 2 to 18 who are at high risk, or who are at high risk due to asplenia, which is just a big fancy word for your spleen is not functioning very well. Also to children who are immunocompromised or have immunodeficiencies, children with HIV, or live in or travel to a country where meningococcal disease is an epidemic. These are the people who this is given to. Avoid if allergic to the previous dose. Again, here we go. If they've had one and had a problem with it, don't give it another one. Use caution in children with moderate to severe or acute illness. Okay. Meningococcal subgroup B vaccine is contraindicated if the woman is pregnant or lactating or a severe allergic reaction to the vaccine previously. They would not take this. If they have any allergy to any part of the vaccine, including latex. So this is one that has this latex component. That doesn't mean that it necessarily has latex in it. It could just be part of how they have to use to stabilize the medication. But there are several people who have latex allergies, and this is where it's important when you're looking at those vaccine information sheets that you determine what exactly could this potential person be allergic to. So just like eggs can be identified, we can identify a lot of people who have latex allergies. More to go through, and then we'll start in on some of the disease processes. And this one is the Tdap, and this is the tetanus, diphtheria, and pertussis. Some of the things to know about that is that for pregnant women, whether they're adolescent or of age, shall I say, women, they should receive a dose of Tdap during each pregnancy. So that would be somewhere ideally within the 27th or 36th week of pregnancy. And it does say each pregnancy, so even if the woman were to have pregnancies, you know, within a year or two of each other, they still recommend that they receive this injection during that pregnancy. It is contraindicated with severe allergic reaction to the vaccine or any components, just like all the other ones I've been telling you about, or to anybody who has had encephalopathy within 7 days of the previous vaccine. And remember, because this is done in 10-year cycles once they get through that initial phase. Use with caution for those who have unstable neurological conditions, a history of arthritis-type hypersensitivity reaction from the previous disease or the previous dose. And you can see what that is in the parentheses. It's just a localized inflammation of pain and tissue destruction, or moderate to severe acute illness. Those people should be cautiously given this injection. And last but not least, we get to HPV. The most common side effect with this one is syncope. So you want to make sure that the patient is sitting for a few minutes after this is given. This is for the human papillomavirus. HPV is known to cause cancers, certain cancers, especially cervical cancer is the one most people think of, but there are a few others that are associated with HPV infection. So this one's relatively new. It first came out in 2006. They recommended that girls in particular, when it started, it was mostly girls they were giving this to, but they will now give it to both men and women because, like I say, we know it covers more than just cervical cancer. It is contraindicated with a severe allergic reaction to the vaccine or the components, and you are to use caution when giving this to women who are pregnant or who have moderate to severe acute illness. Those are some of the things you have to be careful when you're giving this to them. Here are some important nursing responsibilities when administering the vaccine. Document parental consent, acquire up-to-date information, and follow manufacturer's recommendations. Review common side effects with the parents or the patient. Give multiple administrations in different sites and record in the medical record, or E, all of the above. And of course, the answer is all of the above. You would do all of these things. Keep in mind that when you're talking about like your 2, 4, and 6 month shots, and even your 4-year-old shots, these children may be receiving multiple vaccines. So it's important that you rotate those sites around as you're giving them, just because you don't want to put too much medication into one muscle group. Before we get into all the different communicable diseases, we're going to just do a review of the types of isolation. And this is something that you would have covered in first year, but we're just going to take kind of a look at each one of these. Of course, standard precautions are just what they say. They're standard, they're universal, they're things that we do that apply to the possibility of contamination with blood or body fluids, and that is all the protective barriers that we use, like our gloves, our gowns, our masks. If we feel like we need to, there's risk of splashing, we use eyewear. Hand hygiene falls under this one. The no recapping of needles or safeties on our injections. Safe handling of contaminated equipment and isolation techniques are critical for you to know for each one of these because number one, you need to know them to safely take care of people, and two, you will need to have a good understanding of these when you get ready to take your NCLEX examination. So looking at the contact precautions, the first one there, this is for direct or indirect contact. With direct contact, transmission is made directly from the patient to another person. So this is body fluids, blood from that person, enters the body through cuts in the skin, punctures through a needle stick. So this is, gloves come to mind first off when I'm thinking of possibly touching something that can enter your body because you may have small cuts that you're not aware of. Indirect contact can occur when the infectious agent is transmitted through objects such as contaminated linens, coming into contact with your clothes or to your with your skin. This is a good way with children, especially in daycares. A lot of times if you have contact type illnesses, that's why a lot of them share the wealth, shall we say, when they go to daycare, because they often play with the same equipment, and that's why it's important for daycares to clean and all that kind of stuff to help prevent that spread. So contact isolation requires that you wear gloves, that you wear a gown, and if necessary, if you have to move the patient, the infected areas on that patient should be covered. So if they had a wound that was contaminated, you wouldn't want to take them out without covering that wound up because you wouldn't want somebody else to make contact with it. And then we have droplet precaution. And I always think of a lot of respiratory when I think of droplet. So those respiratory droplets will carry that infectious pathogen and transmit the infection when they travel directly from your respiratory tract and affect somebody who is susceptible through usually the mucous surfaces of the other person. They usually don't travel far distances, but they do necessitate facial protection. So a mask is required for droplet precautions, and I'm just talking like a regular mask that we've been wearing typically in the hospital. Goggles if you're within close contact and there is a risk that those pathogens could come out and get into the mucous surface of your eye. Patients should also wear a mask if they're being transported to another area. So if you had a patient who was on droplet precautions who you needed to take down for an x-ray, you need to put a mask on them before you allow them to leave the room. And then last, you have airborne precautions, which we are much more aware of these after the COVID outbreak. Used to be most people that we put in airborne were TB patients, but these particular pathogens are transmitted by airborne routes, and so they require special handling of the air and the ventilation systems. That's why these patients are put in like the negative pressure rooms. They're specially designed so that everything that comes inward. So basically, if you open the door, stuff couldn't come out into the hallway. They typically have like your ante rooms where you have a room where you can doff your PPE and stuff like that. The room should have 6 to 12 air exchanges per hour. You do need to wear a mask. They need to be special masks like the N95 type mask. For those people who can't be fitted with a mask, they have something called a PAPR, P-A-P-R, which is a system that you can put on that comes with it's a nice little hood, and it has a little fan and motorized belt that just kind of circulates the air and keeps everything fresh. And these patients also, if you were to take patients out of a room that are under airborne precautions, they also need to wear a mask when leaving the room. And this does not have to be an N95, it just needs to be a regular mask before you take them out of that room. Some of these childhood communicable diseases that are common. We're going to start with the ones that are considered viral exanthems, and exanthems just means rash on the skin. So if you think back to the activity we did in class, you saw lots of these things had rashes, like your rubeola or measles, your rubella, the German measles or 3-day measles, the erythema infectiosum, other words known as Fifth disease, roseola infantum, okay, or varicella zoster or chickenpox, and shingles is also in this family as well. So it's really important whenever you have a child that presents with a rash that you get a good history, because that helps the doctor determine what they think might be going on. So get a detailed list of things like when did the rash first appear, where did you first see it, how did it progress, like did it start on the face and move down, did it start on the chest and move outward, any other physical signs and symptoms that the child may have had. Did they have a fever? Did they have body aches and pains? Did they have a headache? Okay. Specific details such as the color, whether it was a raised rash, was it flat, did it have any particular pattern or shape, location, distribution of stuff on the body, were there drainage from any of the rash areas, like did they form blisters, did they break open? And also you want to get a good set of vital signs. Assess the child's general state of health. Like I said, do they have a fever? Were they exposed to any recent people who were sick that you know of? If you know the child has had an exposure to Fifth disease, for instance, and suddenly they come and start appearing with a rash, that's a good indication that that's probably what is going on here, and that helps the doctor out a lot. And then treatments typically are things that are over the counter, and it's used more for just relieving symptoms more so than curing it. Most viral infections, I should say, just need to kind of run their course. And then we just need to be watching for secondary complications. First viral exanthem that we're going to look at is the rubeola or measles. This is RNA virus. Incubation period for this is 8 to 12 days from the exposure to the onset of symptoms. They're usually infectious those first 3 to 5 days before the appearance of the rash to 4 to 6 days after the appearance of the rash. This is transmitted by direct contact with droplet, or airborne is less common, but this is more droplet. Natural disease for immunity, or you can give those live attenuated vaccines. And the season that you most typically see this particular viral infection is winter and spring. So children usually experience the prodromal period, which is those light kind of signs and symptoms with a fever, and then it kind of develops with the other symptoms. This is the one that has those 3 C's, that coryza, or that runny nose, kind of congestion in their head, cough, and conjunctivitis, or inflammation of the lining of the eye. And this can last for 2 to 4 days. This is the one that gets those koplik spots, which are small bluish white spots with a red underbase to them that can appear in the buccal mucosa. So if you were to kind of pull their mouth open and look at the sides of their mouth, you'd see these little patches appear there. The rash is a deep red. It's a macular rash that begins on the face and neck and will spread down the trunk and of the extremities to the feet. So again, that's why it's important to get a history on how the rash started and where did it go. Measles are uncommon in our country, in the United States, due to the vaccination rates, but it still does occur in other countries. And then a vitamin A deficiency is another contributor to measles, and treatment is usually symptomatic, which is pretty common for a lot of these viral infections. And there are some nursing care plans in McKinney for specific child care that I would encourage you to review on this one. Disease that falls into this viral exanthem is rubella. And again, this is caused by an RNA virus. Incubation period is 14 to 21 days. Infectious period is 7 days before the onset of symptoms to 14 days after the appearance of the rash. So it's really easy to see how easily a lot of these diseases can spread. As I go through these, you'll notice that the infectious period oftentimes occurs before the onset. Like I said, those beginning phases where they're in incubation and that early prodromal phase where we don't even know they're sick, that's where they're really most likely to spread this. Transmission is also airborne or direct contact with droplet or transplacental, so this can go across the placenta. Immunity is usually through natural disease, either catching it or by these live attenuated virus. And this season, usually we see this in late winter to early spring. So some young children may be asymptomatic until the rash develops, so you don't even know anything's wrong with them, and then all of a sudden they pop out with a rash. Older children may get some like nasal stuffiness or drainage. They can have some diarrhea. They'll have a general feeling of just not feeling well. They could have sore throat, low-grade fever, body aches, chills, eye pain, headaches, nausea. They may not want to eat. They may have enlarged lymph nodes, but the rash for this one is usually a pinkish maculopapular rash that begins on their face, the scalp, and the neck. It's often pruritic, which means it itches, and it spreads to the entire body in 1 to 3 days. You may also see petechiae appear on the soft palate, so if you were to look in their mouth, you would see these little tiny purple-looking spots. Those are usually small little hemorrhages or small little bruises. And I am not German, but I'm going to try to pronounce this. That is actually referred to as Forchheimer's sign. And one of the most important things to remember about rubella is its ability to cross the placenta during pregnancy, because this one can lead to fetal death or abnormalities. So great care should be taken if you have a child with this, that they not, around an expectant mother, or the mother needs good prenatal care to ensure that she has immunity from this particular viral infection. Along with erythema infectiosum, or fifth disease, or parvovirus B19. Very obvious causative agent is the parvovirus B19. Incubation period for this one is 4 to 17 days, but can be up to 28 days or 4 weeks. Infectious period, shedding of the virus between days 5 and 12, usually infectious from the prodromal period until the rash first appears. So you can have a very long window of time that the child can be infectious with this one. Transmission is usually airborne through respiratory droplet, blood products, transplacental. Immunity from this one is natural, just occurs because the person has been exposed and they build antibodies. We usually see this in late winter and early spring. So this is common in children, but not common in disease. It really is a fairly mild disease, although they look really sad because of those bright red slapped looking cheeks that they get. Sometimes the rash can come and go. The child may experience mild symptoms of runny nose or a headache. They may be asymptomatic approximately 1 to 4 days after the facial rash appears, with this red maculopapular rash appears on the trunk as well as the extremities, and then eventually fades with a central clearing area that appears lacy. The rash can last anywhere from 2 to 20 or 39 days, and it can reappear with aggravating environmental factors. So like if they were outside in the wind or it was too hot. And pregnant women should also be notified if they get exposed to this virus, because it also can affect the unborn baby. On to Roseola infantum. Causative agent is a human herpes virus 6 or HHV6. Incubation period is 5 to 15 days. They are infectious, really an unknown time, but may extend from the febrile stage or when they first start to show fever to the time the rash appears. Transmission, this is direct contact with secretion, and there is no seasonal pattern. So this one, usually we can see at any point. Most cases do occur in infants from the ages of 6 to 18 months of age. The child could experience a sudden high fever. They can have a general feeling of not being well. They may be irritable, but they may remain active. They can have intermittent fevers. I just realized that word is misspelled there, but intermittent fevers that may last for 3 to 5 days, and the child may cough, have runny nose, abdominal pain, headache, throwing up, or diarrhea. So this one can affect the GI tract as well. After several days, the fever will subside, and within several hours to 2 days, the rash can appear. The rash consists of a rose pink macules that blanch when you press on them. So when you push down on them, they turn white, and it is predominantly on the neck and trunk, and then they have a white ring on them. Usually management for this is symptomatic. You do need to watch for febrile seizures because these children do have high fevers, and so that's always a risk. And so you need to be taught to monitor the fever and give appropriate Tylenol dosing. And parents should understand the absolute contraindication of giving aspirin to children due to the risk of Reye syndrome, which is something that can happen when you give aspirin to children with high fever. The other thing I would think about with this one is, with this age range of 6 to 18 months who have high fevers, they have the risk of having vomiting and diarrhea. You have to worry about the possibility of this child also becoming dehydrated, and that can also fuel the fever to be higher if the body is not well hydrated. So just something also to keep in mind, that you encourage the parent to give clear liquids and make sure the child stays as hydrated as possible. All right, moving right along, we're on to varicella, chickenpox, or shingles. This causative agent is the varicella zoster virus. Incubation period for this one can be 10 to 21 days. Infectious period can be 1 to 2 days before the onset of the rash until all the lesions are dried. That usually occurs between 5 and 7 days. This one is transmitted through direct contact, droplet, or it could be airborne. Immunity usually is natural or vaccine. Now, I say usually, it used to be usually natural, now it's more vaccine. And we usually see this most in late winter and early springs. This one just appears as a macular rash 24 to 48 hours after a slight fever, general feeling of not being well. They may not eat that much. And usually the lesions appear in crops. So a lot of times they'll get on the trunk or on the scalp, and then they do move outward. So it's central moving out. They may also become present in the mucous membrane, so that could get in the mouth, which is very uncomfortable, hard for the child to eat and drink when that happens. They usually begin macular and develop into papular, and they move to teardrop vesicles with like a red base. The vesicles usually become pustular, and they will then begin to dry out or crust over. Some of these will pop. You may see exudate, like when you wake the child up, there may be stuff on the sheets. But the vaccine did become available in 1995. Some children would become very ill with chickenpox, and it could even result in death. Like I told you, they would have chickenpox parties and actually bring their kids, so everybody would get sick at one time. So if you're going to have one kid with the chickenpox, you might as well have 3. Just get them one and done. But now we do have vaccines, so children don't have to go through all the lovely chicken pox. Initial infections with this that causes chicken pox later down the road, if that person has had it, they can develop shingles later on in life because the virus will actually lie dormant in the body, but still present. And so as the patient gets older, they can then develop shingles, which is very similar. They'll get this rash, but there's a lot of pain associated with that because they usually are involved with nerve roots. So treatment for this is symptomatic. Most common complication is secondary skin infections because they do itch, they do drain. You think about a 1-year-old getting chickenpox, you can't tell them to scratch something that itches because they don't understand that. And so they do, and so they can get open lesions and infections there. So parents basically need to be educated on how to keep the child comfortable. We used to give them like little oatmeal baths, put some kind of anti-itch medication onto the wound itself. Also proper use of antipyretics like your Tylenol or your ibuprofen to help with the fever, antihistamines to help with itching, and making sure that you keep the skin and underneath the nails clean so you decrease the risk of those secondary infections happening if you can do that. Okay, so some other viral infections that we see with children are mumps, the Epstein-Barr virus or mononucleosis, the Coxsackie viral infection, otherwise known as hand, foot, and mouth. These are all important to understand. Mumps infections can be transmitted or transferred airborne or through saliva, and the child can be infectious for 7 days before the swelling happens, up to 9 days after the onset of the illness. The patient usually has a fever, they have a general feeling of just not being well, and then the classic symptom, which is the swelling of those parotid glands. So they kind of look like they got hamster jaws. If you've ever had a hamster that fills their mouth full of food and they get that big puffiness on the underneath their like chins, that's what people with mumps can look like. It can be quite painful. The most common complication is that when the virus is identified in the CSF, it can cause meningitis, which then can cause the nuchal rigidity, the vomiting, the extreme lethargy, and the children generally have complete recovery from this, but they can be quite sick during this process. Luckily, again, we have vaccination for mumps now, so we don't see this as often, like the horrible cases of this. This is also the one that can lead to male sterility for people who have had mumps. Mononucleosis, this is the one that's also known as the kissing disease. This one is also caused by the Epstein-Barr virus. It is highly contagious and transferred through saliva. Symptoms are, you can have exudative sore throat, okay, and they do have usually a pretty nasty sore throat. You can have enlarged lymph nodes, you can have fever, a general feeling of not being well. They can be mild or severe symptoms. If they have more severe symptoms where they have enlarged spleens or livers, they may have stomach discomfort, which can then affect their ability to eat because they constantly feel like they're full. This one usually lasts about 2 to 4 weeks before they recover gradually, and the disease may reoccur during times of being compromised, the immune system being compromised. Complications do include a rash or, like I said, inflammation of the liver, which is that hepatitis. And one of the big things, like I told you in class, that we worry about is the spleen enlargement with this one, that if they were to take a blow to the abdomen, the spleen is very, very vascular. And so when it's inflamed like that, it's more likely that you could potentially rupture it with blows to the abdomen, which could then be life-threatening because the patient could actually hemorrhage to death at that point. Again, treatment is simply symptomatic and supportive. Antivirals seem to have little effect on this virus, so it's kind of like you just got to let it go and let it run its course. When we get to the oncology lecture, we're going to talk about this one again, because Epstein-Barr, someone having mono, does put them at an increased risk later on down the road of developing some lymphoma, which is a type of cancer. Doesn't happen very often, but it is a risk factor. And the last one is this Coxsackie viral infection, or hand, foot, and mouth. This one is caused by various enteroviruses. Incubation period is 3 to 6 days. It's transmitted by the fecal-oral route. That's why hand washing is so important. Contact precautions are implemented for infants and young children, and most commonly this occurs in the summer and in the fall. It usually presents in both infants and children. They typically will have a nonspecific fever with a variety of respiratory, GI, and skin symptoms, but other systems can be affected. This one is usually this does get the vesicular type lesions that develop on the hands, the feet, and the mouth, and the lesions usually resolve in about 7 days or a week. There is a risk of bacterial infections and open lesions. This is what I was talking about with my grandson that wound up with staph in his hands and on his chest. So management is really based upon treating the symptoms. Dehydration can occur, especially if it gets in their mouth, because it makes it very difficult for them to want to eat or drink. We can have them go without eating for a few days, but children really need to stay hydrated, and it's really easy for young children to dehydrate rather quickly. So close monitoring of their fluid status and replacing that as needed is very important for these children. Okay, so we're going to look at some of these bacterial infections, things like pertussis, MRSA, C. diff, strep, staph, E. coli, and scarlet fever, and rheumatic fever. So pertussis is the one that's also known as the whooping cough. Like I told you in class, unfortunately, we have seen a resurgence in this again, sometimes due to poor vaccination compliance. So that's what they're saying. And then there are 3 stages to pertussis. So you can see them here, this catarrhal, paroxysmal, and the convalescent stage, lasting a total of 6 to 12 weeks. Complications of pertussis include pneumonia and altered airway patency. Compliance with 5 doses of the DTaP vaccination followed by a booster at age 11 to 12 is recommended to prevent whooping cough. So that's what they're saying about poor compliance. Maybe the child received the first 5 doses but didn't, or should I say those first 4 doses when they were younger, but didn't follow through with the booster. And so then we wound up with problems down the road where we saw a resurgence in pertussis. And this one, like I said, if you've ever seen a child with this, they literally like cough till they just heave. I mean, it's just like this sustained, it's a horrible thing to kind of watch. If you've ever seen a child with croup, it kind of reminds you of that. MRSA, or methicillin resistant Staph aureus, is becoming more prevalent, unfortunately. And Staph aureus is just a bacteria that grows on the skin. But unfortunately, because of a lot of antibiotic use, we've kind of developed this superbug that's resistant to methicillin, which was the drug of choice. So some risk factors include a history of chronic illness, people who are immunocompromised, close contact, team sports, and daycare attendance. I saw this a lot when I was a school nurse with the team sports. People who were especially wrestling, they were on mats, that kind of stuff. Close contact in the locker rooms with the football players and things like that. So Clostridium difficile is a fairly common cause of diarrhea in children. It's usually associated with antibiotics use because our bowels have normal flora that's supposed to be there. We give antibiotics. It kills off the bad stuff that we want it to, but then it also turns around and kills off the good stuff that keeps that C. diff in check, and so then it's kind of like a super infection, just kind of takes over. So the treatment for that one is usually oral metronidazole and or vancomycin, and I usually see vanc used more than anything in the hospital. And then scarlet fever and rheumatic fever. So scarlet fever is an illness that is caused by a bacterial infection. And rheumatic fever is an inflammatory condition that can develop if scarlet fever is not identified and treated. So scarlet fever, if untreated, can develop into this rheumatic fever. And this is the one that is associated with the strep infections on this one. So this one would be treated with antibiotics. Talk about some rare viral and bacterial infections. I can say rare, and I'm kind of grateful for that. But poliomyelitis or poliovirus, diphtheria, and then a little bit about the Tdap or DTaP vaccines. I say, rare now. Polio at one point, I want to say it was in the 50s, was rather rampant, and parents were terrified because this virus would come along. It would basically paralyze the respiratory tract, and these children would not be able to breathe, or adults would not be able to breathe. They would put them in a machine called an iron lung that would help them breathe. It also could result in paralysis of the lower extremities that could leave, devastating consequences for the person. And so we were very fortunate that they developed a vaccine for polio, and we were able to start using it, and that vaccine has even evolved. It used to be a live vaccine, and like I said on an earlier slide, they would drop it onto a sugar cube or a spoon of sugar, and the child would then take it. Now it's an injection with an inactivated type virus. So, but this was something that was very, very scary and killed people, and now luckily because of vaccination, it's very rare that we see polio in people anymore. Diphtheria also begins with a mild respiratory type symptom, so it's kind of comes on like a very, very common cold, and then it progresses to respiratory compromise with narrowing of the airways, which you can see how that could be very frightening. Narrowing of the airways, that person could go into respiratory distress, respiratory failure. So the Tdap or that DTaP vaccine stands for diphtheria, tetanus, and acellular pertussis, and is given in 5 doses beginning at age 2 months. The Tdap stands for tetanus, diphtheria, pertussis, and is given as the booster. So that's the big difference. The DTaP is the one that's given in those 5 doses beginning at 2 months. And then the Tdap is the vaccine that stands for tetanus, diphtheria, and pertussis, but that is the actual booster. So you'll give DTaP to the little ones, Tdap as the booster. And then this one's on your objectives, and I really was kind of confused by this because I don't think of Lyme disease as a communicable disease, because it's not something that can be passed from person to person. Like that's what a communicable disease is, but it's on your student learning outcomes. This one, we're kind of familiar with it down here in particular because we live in, tick country. But Lyme disease is a bacterial infection caused by Borrelia, which is transferred to humans by ticks. So the ticks are the ones who are the carriers, and then they pass it to us. There are 3 stages: the early localized, the early disseminated, and the late disseminated. So this can be a concern for children who especially live in wooded areas or who like to play outside frequently. I always think I have 2 grandchildren. My daughter has her little farm, and my grandchildren are always outside playing in the woods, on the swings, climbing trees, all that kind of stuff. But early stages include localized reaction to the bite and vague flu-like symptoms. They just kind of don't feel good, a little bit achy, okay? And then the second stage comes in about 1 to 4 months after the tick bite, and this has the central nervous central nervous system symptoms with the severe joint inflammation and carditis or inflammation of the cardiac muscle. And then your late disseminated disease can persist for months to years and cause extreme fatigue and cardiac complications in children. So prevention is the key here. So this is teaching the parents to make sure when your kids are outside, use insect repellents properly. You may have to reapply them. Make sure when they come in, you're inspecting their skin so that if you see a tick on them, you can get it off quickly. And that's just educating the parents about prevention. It's kind of like teaching them to use sunscreen. Infections are usually treated with antibiotics, and the parents must be taught the importance of completing the course of the antibiotic or the medication, which is true anytime we put someone on an antibiotic. We preach and we preach and we preach. Make sure you complete the full course. Don't just take it till you feel better. Okay, so we're going to talk about tuberculosis, which is another one of those bacterial infections caused by the Mycobacterium tuberculosis, or it's a type of acid-fast bacillus. This one is transmitted by droplet nuclei from person to person with active TB through airborne particles. I did change this the way it was written at first. I'm like, it makes it sound like it's droplet, and I know there's a lot of talk with this. Is it droplet versus airborne? But it is droplet nuclei, but it is through airborne particles. Therefore, when we have a TB patient, we use airborne precautions. And so I rewrote this because I thought that looks really confusing. And if you've studied anything about TB or you've taken care of TB patients and they've been in airborne precautions, I didn't like the way it said droplet before because of the way that connotation gave that it was a droplet precaution. We do the skin test or those PPD tests. These are the things that you guys are asked to do every year. And I'm going to just take this time to plug, if you've not turned that in, get it to me. There's also a difference between exposure, infection, and disease, because you can be exposed but not actually have infection. Okay, you can have active infection or you could long-term with this. Okay. So this is another communicable disease. Approximately 5% of reported cases of TB in the U.S. are in children. It's most frequently seen in infants and adolescents and children with immunocompressive ailments, or they're immunocompromised. I did give you the page numbers, I should say, in McKinney, which starts on 1072 through 1074, that you can do the review for risk factors of developing it. The skin test is performed on children with no risk factors. The test will become positive in 2 to 10 weeks after the initial infection. You guys have all seen how those are done as far as the PPD, which is then done, the 48 to 72 hours after the admission. They also can do blood tests for this as well. And when I say the test will become positive 2 to 10 weeks after the initial infection, because I just said that, I'm like, that kind of sounded confusing too. The PPD, when you're doing it, where you do the intradermal, and then you come back and they feel for induration, that test is done in 48 to 72 hours from the time you put the little glove underneath the skin to the time you check it. The child will not test positive for 2 to 10 weeks after they've been infected. So if the child is just in that first week of infection, from time of infection, they may test negative. So I just want to clarify what those two things mean. Children with the positive test will undergo further treatment, and that's the case with adults too, where they will do chest x-rays to look at the x-ray. They'll also do sputum cultures to see if they have any acid-fast bacillus growing in there. That's something that you typically will do when they're in the hospital. If they're under your care. TB exposure is contact with an individual who has active TB. So if, like I say, you're with somebody who you know has active TB and you were unprotected, you have now had exposure. The infection is having the positive skin test, and TB disease is the combination of having the chest x-ray that changes, the positive test, you have symptoms, disease, and all that kind of stuff. And treatment usually includes a 6-month course of a combination of anti-tuberculosis medications. And this, again, is very, very important that patients understand that this is a 6-month course and they must complete the entire course of the medication. Okay. Okay, so what lecture about communicable diseases would be finished if we did not talk about COVID-19 or SARS-CoV-2? Symptoms tend to be less severe in children. This can be a source of transmission, though, to others. The CDC does recommend vaccines, and I talked about this earlier. This text needs to be updated to say age 5 or over. I know they're doing studies and trials on children even younger than that, but that age range has changed from 12, but don't worry, on a test purposes, I'm not going to give you anything like that. Okay. let me see, I've got some stuff written down here. You know, Delta variant is, of course, affecting or was affecting young children. We see much more of the Omicron now. There is some Delta. Delta seem to be more serious as far as side effects and making people sick. Again, children seem, though, to recover well from that. They didn't seem to get as sick as that, but they can be little spreaders because keep in mind they are not very mindful, especially the younger children, about keeping their mouths covered. They don't like to have the masks on their face and things like that. So they can be good spreaders to other people. Let's see. There have been some cases where the children do wind up with myocarditis or pericarditis in adolescents and in young adults after receiving the vaccine, but that is very, very rare. There are, I know with, especially, I saw this more with the Delta variant, where we were seeing people having effects on the cardiac muscle, and some of these patients were winding up with pretty significant heart failure. Even young patients who now are requiring, being on a transplant list. We're seeing the long haul COVID patients with the respiratory scarring and stuff like that. So hopefully I feel like you guys are pretty versed in COVID-19 because we've all lived this for the last 2.5 years. But just be mindful that this one is still out there. We're probably going to be dealing with this for the rest of our lives. I wouldn't be surprised to see COVID vaccines yearly, or maybe every couple years like we had the flu vaccine. Prevention is key when it comes to communicable diseases or diseases that are easily spread from one person to another. That's why we stressed hand hygiene, good washing of your hands. This is one of the first things they teach preschoolers, kindergartners, is washing your hands after you use the bathroom, before you eat. Okay, so make sure that you're teaching that to your children. Taking your children for regular well child visits and exams. Educating your parents on the importance of following recommended vaccination schedules. I say that, but you still also need to be reminded and be mindful of the fact that there are going to be some parents, for religious or very personal reasons, choose not to vaccinate. And our job is not to judge those parents for making those choices, but to just try to provide education to them as to why vaccination is important. Like I said, a big thing for us as nurses is prevention. It's a lot easier to prevent it than to treat sometimes, especially if the children were to come down with, one of these illnesses that could leave some long-lasting effects. And then last but not least, I told you that I like to use resources for you guys. I am a video person, probably because I am a very kinesthetic and visual learner. And so having a video that I can watch is very helpful. So I love Registered Nurse RN. That's Nurse Sarah, and she does have a YouTube video about pediatric vaccine schedule and mnemonic for immunizations made easy. And it is a great little 5-6 minute video to give you guys just a quick, easy way to remember when children get what vaccines. And so I highly recommend that you take a look at this one.